It's my pleasure to introduce Michelle Violi. Michelle is a licensed pharmacist with a passion for bioidentical hormone health. She received her PharmD degree from the University of Wisconsin-Madison School of Pharmacy. At Women's International Pharmacy, she is the dispensing pharmacist manager, where she is responsible for managing a team of pharmacists and pharmacy technicians in 2 locations. She participates on the regulatory team to maintain state licenses and is an active contributor to Women's International's educational resources. Michelle is a member of the Alliance for Pharmacy Compounding and Pharmacy Society of Wisconsin, as well as holding 18 state licenses. She's committed to the future of compounding as a pharmacy student preceptor with both the University of Wisconsin-Madison School of Pharmacy and Concordia University School of Pharmacy. It's a real pleasure turning this over to her. Michelle?
My name is Michelle Violi, and I'm the dispensing pharmacist manager at Women's International Pharmacy. We are a compounding pharmacy. We've been compounding for over 35 years, and I myself have been here almost 20. So I feel that I am well equipped to talk to you about what you need to know about cBHRT and mental health. And for those of you that aren't familiar, cBHRT is a relatively new acronym. It stands for Compounded Bioidentical Hormone Replacement Therapy. So with that, let's get started. So first, I'm going to take you through a little bit about pharmaceutical compounding, just so that you have a little bit of a background before we move along. Pharmaceutical compounding is the combining of one or more active ingredients into a customized treatment for an individual patient's needs. And I think that that last part about the individual patient is the most important part. Compounding is able to address many, many different needs for a patient, as opposed to maybe what you would find at a traditional community pharmacy where medications are pulled off the shelves and put into bottles. Why might you choose compounding for your patient? I've listed a number of examples here. First of all, adding flavor to an oral liquid to make it more palatable for a child or a pet. And I personally have a child and 2 pets at home, and I can attest that a palatable liquid is much more, it makes the situation much easier than trying to get either to swallow something that's bitter or nasty. The next example would be combining multiple medications into one dosage form for convenience and improved adherence. And so I think all of us know that taking 1 capsule a day is much easier than taking 3 or 4, and patients are much more likely to follow that regimen. Next, we're able to provide alternative dosage forms for patients who can't take medications orally. So, for example, perhaps somebody has had a stroke and isn't able to swallow as well as they once were. Maybe a topical dosage form would be more appropriate. Next, using ingredients appropriate for chemically sensitive patients. And we see a lot of very chemically sensitive patients, as I'm sure you do too in your practice. Compounding pharmacies are able to compound creams and gels and tablets and capsules with the ingredients removed that perhaps these people are sensitive to. And then lastly, although certainly not least, making minute dosage adjustments. As I mentioned before, at your typical community pharmacy, perhaps you have 5 or 6 dosage options when a patient goes to pick up a medication. With a compounding pharmacy, your options are infinite. We can make very, very minute dose adjustments to make sure that the medication is exactly what the patient needs. Let's talk about quality. I know that in the news media over the years, you've heard things about maybe compounding pharmacies not having good quality, or specifically about some certain bad actors that we are unfortunate to have in the industry. And so it is important to look at who you're working with and to determine if the pharmacy you're working with is the pharmacy that you want to work with. The first step, I think, is to look for national accreditations and good compounding practices. For example, the Pharmacy Compounding Accreditation Board offers an accreditation known as PCAB accreditation. And this particular accreditation is a service of the Accreditation Commission for Healthcare, which facilitates many different accreditations throughout healthcare systems. And I can tell you from experience that this is a very stringent approval process. The PCAB board goes in and inspects every 3 years and requires reports throughout the years, not just every 3 years. And it's a very thorough investigation of all policies and procedures, looking at the actual compounding process itself. It's very thorough. Compounding pharmacies are also required to follow certain compounding standards as established by the United States Pharmacopoeia, also known as USP. This is a nonprofit organization, and they develop and publish standards and related programs to help ensure the quality, safety, and benefit of medicines and foods. And so the USP establishes standards for pharmacy throughout healthcare systems. However, there are a number of standards that are specifically related to compounding. The first that applies is USP 795, and that is with regard to non-sterile preparations. There is also USP 800, which has guidance on hazardous drug handling. And then I'm not going to talk about it today, but there is also a USP 797 that talks about sterile compounding. Pharmacies and pharmacists are also required to follow their state laws. Some pharmacies may be licensed in multiple states, and they would need to follow then the state law in all of those states. These entities are licensed and strictly regulated by state boards of pharmacy. Compounding is and always has been a core component of pharmacy and has always been subject to the oversight and monitoring of these agencies and the state. And most states have very stringent law with regard to compounding pharmacies. In 2013, the Drug Quality and Security Act was enacted, known as DQSA, and that allowed the federal government some authority over compounding as well. So the FDA now has authority over some aspects at the federal level. And so I think looking at all of these laws, I've often heard compounding pharmacy isn't regulated enough. And in fact, compounding pharmacy is very regulated. It's just a matter of making sure that those laws and rules are enforced and followed. So let's move on to how to use a compounding pharmacy. It's really very much like just using any community pharmacy. You can submit prescriptions by fax, phone, mail, or even electronic prescribing. And I think so important to keep in mind is that pharmacists are here to help. I can imagine it would be pretty intimidating to go from having maybe 5 or 6 different doses to choose from to going to an infinite number of doses and dosage forms. And so if you are unsure or if you need guidance or would just like to bounce some ideas around, please contact a pharmacist at a compounding pharmacy. That's what we're here for, and that's really what we enjoy about our job. In compounding pharmacy, we really emphasize the collaborative effort that pharmacists, practitioners, and patients all put together to contribute to the health of the patient. And so we always make sure to include the patient and the practitioner whenever any medication is being prepared. Certainly we need a prescription from the practitioner, but also including the patient, making sure that we understand what their sensitivities are, what their preferences are, and just making sure that the communication between the three is open and strong. With regard to dosage forms that are available, most compounding pharmacies are able to compound oral capsules and tablets. Regarding the sublingual route, capsules, lozenges, and drops are available. Topical creams, gels, and non-alcohol gels can be made for topical use. For vaginal and rectal routes, suppositories are available, but also topical creams, non-alcohol gels can be used vaginally and rectally. We've also seen drops and capsules used vaginally and rectally, so there are a lot of options there. And then some pharmacies do injectables and pellets, which would fall under that sterile component of compounding. Something else that is really nice about compounding is we can alter the delivery device for the patient to make sure that it is what they need. For example, if the patient is using their cream topically, or if the patient is using the cream vaginally, perhaps a tube with an applicator would be the best choice. If the patient needs a little extra help measuring for their topical dosage form, there are metered dose containers available. And then for drops, syringes and droppers can be used to make sure that the dose is measured in the most accurate way. So now let's get to the meat of it. This is, I think, why we're all here, is to talk about hormones and how they can affect mental health. First of all, what are bioidentical hormones? And some of you may be very, very familiar with this, but I want to make sure that we're all starting from the same base here as we move along to talk about how hormones affect mental health. I've decided to focus specifically on bioidentical hormones as opposed to some of the synthetic forms that are available commercially. So bioidentical hormones are hormones that have the same molecular structure as those made by the human body. I like to look at this graphic here to really show and consider the difference between a bioidentical versus a synthetic hormone. So if a bioidentical hormone is exactly the same as a hormone made by the human body, a synthetic hormone is somehow different. The chemical structure has been changed in such a way that perhaps it needs to last a little bit longer in the body. That's one possibility. Perhaps the maker wants to patent it. Of course, you can't patent a natural substance like a bioidentical hormone, so that's another reason. But if you consider that the hormone is a key and the receptor is a lock, consider what happens when you try to put a key into a lock that just doesn't fit. It just doesn't work. The door doesn't open. Some keys may fit into the lock but not turn. And in that situation, if you think a little bit more broadly here, perhaps the key does turn, but it doesn't open the door. It turns on the outside light, or perhaps it opens the window. But what we're looking for is for the hormone to open that door. And in order for that to happen, the hormone needs to be a perfect match to the receptor and needs to be what the body is used to looking at, which is a bioidentical hormone. I love this chart. As somebody who has studied chemistry and pharmacy for many years, this looks like a fun graphic to me. But what I do want to point out is that everything starts from cholesterol. You can see that up in the upper left corner. Comes down to pregnenolone, and then one hormone moves to the next, ending somewhere around either the adrenal hormones or estrogen, testosterone. And so as we're moving through this conversation, I think it's important to consider that each of these pathways requires enzymes, requires cofactors in order to successfully convert from one hormone to the next. And so if the body, for some reason, isn't working as it should, perhaps all of these conversions aren't happening perfectly. I've often heard the question asked, why can't we just give pregnenolone and have the body do with it what it needs to? And that would be my answer, is that not everybody's body is working perfectly as it should. So let's keep that in mind as we move along. First, we'll start by talking about progesterone. So progesterone is secreted in the second half of the menstrual cycle after ovulation by the ovaries and also by the placenta during pregnancy. And it is also made from cholesterol in the cortex of the adrenal gland. And I want to point out that progesterone is the first hormone to really be affected by perimenopause, because as a woman begins to skip ovulations, it's the process of ovulation from the ovary that causes the corpus luteum to form, and that's the gland that produces progesterone during a woman's cycle. And so as a woman passes through perimenopause into menopause, she is reliant upon the production of progesterone from the adrenal glands. And so we'll talk a little bit about it later. I know that you have a lot of background in adrenal fatigue, but if a woman's adrenals aren't working well, menopause can be a difficult experience for them because they're not getting that progesterone from the adrenal glands. Here's another example of the natural versus synthetic situation. Progesterone is known collectively with its synthetic analogs as a progestin. However, there are great differences between the natural hormone progesterone and the synthetically made progestins. And so as you can see from this graphic, if you look at the upper right, there's quite a large group that's been added there. And then at the bottom middle, you can see a methyl group has been added. And so I think we can all kind of picture how that might fit into a receptor differently than the bioidentical progesterone would. So with regard to progesterone and its actions on the body versus synthetic progestins, I think one of the best examples of the difference between the two is progesterone's effects on lipids. So I think we're all probably familiar with the idea that estrogens have a positive effect on lipids. Progesterone does not appear to reverse the positive effect of estrogen. However, synthetic progestins do reverse the beneficial effects of estrogen to varying degrees. And so there we can see quite a significant difference between the two. Where does progesterone act in the body? So during this talk, we're going to focus on the brain and the central nervous system, but it's also important to keep in mind that progesterone has receptors on the bones, in the breasts, in the uterus, and also in the cardiovascular system. A question that I'm often asked is, after a woman has a hysterectomy, after her uterus is removed, does she still need progesterone? And my answer to that would be to refer to this slide particularly and say, well, she has receptors in all of these other areas, not just the uterus. And so yes, it would be important for her to continue to receive progesterone even after her uterus would be removed. On the other hand, with synthetic progestins, I think that the risk of side effects in that situation would outweigh the benefits, and I would not recommend a synthetic progestin. In fact, I would never recommend a synthetic progestin, but just going forward from there. Okay, so now let's talk about how progesterone affects mental health. This first study I found to be very interesting. It was published in Psychoneuroendocrinology, and it looked at the effects that endogenous progesterone has on the development of on the development of premenstrual symptoms in premenopausal women. So we're looking at PMS here, PMS symptoms in premenopausal women. The symptoms that they looked at were depressed mood, anxiety, mood swings, irritability, and a feeling of being out of control. The progesterone levels of women who developed symptoms remained stable during most of the mid to late luteal phase, so immediately prior to menses, and then declined sharply during the last 3 days prior to the onset of menstruation. In contrast, the progesterone levels of women who did not develop symptoms declined more gradually. Interestingly, neither maximum nor minimum progesterone concentrations were associated with appearance or severity of symptoms in either group. And I find that so interesting because over the years, I've heard so many theories about, is it because progesterone levels are too high during the luteal phase or not high enough? Is it a deficiency of progesterone? And this study would seem to indicate that, in fact, it has more to do with how quickly progesterone levels drop prior to menstruation than it does to actual progesterone levels themselves. And so here, you might see progesterone used days 20 through day 2. So maybe, the 8 days leading up to menstruation and even into the period a couple of days just to blunt that decline, and perhaps that may help with symptom control. Moving on to another study. So this study actually looked at using micronized progesterone for the treatment of premenopausal women suffering from PMS. The last study looked at internal progesterone levels, but this one's actually looking at progesterone supplementation, and does that help? So in this study, 37 women received progesterone 100 milligrams sublingually from day 11 to 25 of the menstrual cycle. The treatment group contained 37 women with severe PMS symptoms, and the control group contained 32 women who did not have PMS symptoms. And after 3 months of treatment, about 86% of the treatment group was observed to have full regression of clinical symptoms, and about 13% were observed to have a decrease in clinical symptoms of severe PMS. And so I find this study interesting as well because, as we talked about in the previous study, the symptoms of PMS seem to be triggered by that swift drop of progesterone prior to menses. And in this study, they used the progesterone from day 11 to 25. So they actually stopped several days before menstruation could be expected. So I do find it interesting that they did see success here. I wonder what would happen if they would use the progesterone from day 11, say, through to day 2, or even through to day 28 to even further blunt that decrease in progesterone levels. So now let's move on to estrogen. There are 3 main types of estrogen in the body: estradiol, which is known as E2, estrone, which is known as E1, estriol, which is known as E3. However, there are many more metabolites, and we're not going to get into those metabolites today during this talk, but please do keep in mind that each of these estrogens need to be broken down in order for the body to eliminate them. Starting with estradiol, this is the most potent form of estrogen, and it is the main estrogen produced by the ovaries. This is the main estrogen that a woman's body is exposed to during her premenopausal years. Estrone is 12 times weaker than estradiol, and it can be produced by the metabolism of estradiol in the stomach and the liver. It can also be produced from the conversion of DHEA, which we'll talk about later, an adrenal hormone. And so DHEA can be converted to estrone, and so this is the estrogen that women depend upon during their postmenopausal years. This, again, would be an issue if a woman has a situation of adrenal fatigue or very low DHEA levels, because then she's not getting the estrogen that she needs. Estrone and estradiol can convert from one to the other, and so it is a little difficult to separate these 2 estrogens when we're talking about them. It's hard to know which one does which, but we do know that estrone tends to be converted to some rather less desirable metabolites, and so it is important to make sure that estrone levels don't get too high. Estriol, E3, is the weakest form of estrogen. It's 80 times weaker than estradiol. It's produced by the conversion of estrone in the liver. So this would actually be a beneficial metabolite of estrone. However, there are some not so beneficial metabolites of estrone. And this particular estrogen, because it is so weak, is often used for symptom relief in the vaginal and genital urinary tract. There are many, many receptors for estriol in the vaginal area, and so we often see this used as a vaginal preparation. So let's look at some studies that examined mental health and estrogen. The first study was published in Molecular Psychiatry, and it looked at estradiol for the treatment of treatment-resistant schizophrenia in women of childbearing age. 183 women received, in addition to their stable dose of antipsychotic medication, so this wasn't first-line therapy, it was an adjunctive therapy. These women received either estradiol as a 0.2 milligram patch, estradiol as a 0.1 milligram patch, or a placebo patch for 56 days. And so they found that both estradiol groups had decreases in positive symptoms like hallucinations and delusions, general symptoms like anxiety and depression, and total symptoms when compared to placebo. They did find that the estradiol 0.2 milligram group saw an even greater effect than the 0.1 milligram group. The authors concluded estradiol is an effective and clinically significant adjunctive therapy for women with treatment-resistant schizophrenia, particularly for positive symptoms. And I know that we've all read our share of studies, and the number of studies where I see more study is necessary in order to form a conclusion, that seems to be a large number of them. So when authors actually do conclude that something is effective and clinically significant, I tend to perk up my ears and really pay attention to that. The next study that we're going to talk about is looking at the effects of transdermal estradiol for postpartum depression. In this study, 14 women experiencing symptoms of PPD received estradiol 0.1 milligrams in patch form or a placebo patch. Unfortunately, the study was underpowered due to a small sample size, so the studies weren't statistically significant, but I do think that we can look at them and perhaps point in the direction of studying this further. So in this situation, 3 patients in the placebo group dropped out due to severe depression. 4 of the women in the treatment group experienced remission compared to only 1 of 7 in the placebo group. So while those numbers aren't statistically significant, just looking at them with a little bit of common sense, it does look like maybe we're onto something here. I do want to point out that care should be taken when using estrogen in the postpartum period, as estrogen can interfere with lactation. And so obviously when treating any patient, it's important to weigh the risks and the benefits and the priorities and the things that maybe don't need to be considered as much. If somebody is really in the throes of a severe postpartum depression, maybe choices would need to be made about certain things. The next study that we looked at, or that I'm going to talk to you about, is looking at the efficacy of estradiol for the treatment of depressive disorders in perimenopausal women. So in this study, 50 women with depressive disorders received estradiol 0.1 milligrams in patch form or placebo for 12 weeks. 17 women in the treatment group experienced remission compared to only 5 in the placebo group. The authors concluded that transdermal estradiol is an effective treatment for depression for perimenopausal women. And I think any of you out there that are working with perimenopausal or postmenopausal women, certainly in my own almost 20 years of pharmacy practice, I can attest to many interactions with women who can describe the effects that estrogen has had on their mood. I don't think that this result is terribly surprising, but it is nice to have a study actually supporting what I've been seeing over my career. Lastly, we'll look at a study that was published in JAMA Psychiatry, and this study examined the efficacy of transdermal estradiol plus intermittent micronized progesterone in preventing depressive symptom onset. And I was really happy to see this study because I think that this is probably the most real world that we're going to see, unless a woman has had a hysterectomy. And even then, as I mentioned before, women are going to be using progesterone in combination with estradiol during peri and postmenopause. And so I think it's good to look at the estrogen and progesterone used together and see what happened there. So in this study, 172 women were given estradiol 0.2 milligrams in patch form continuously with micronized progesterone, 200 milligram capsules for 12 days every 3 months, or placebo. This study took place over 6 years, and the women were evaluated quite often at 1, 2, 4, 6, 8, 10, and 12 months. The women who were assigned to placebo were more likely to score higher on an established depression scale than the treatment group. So the women who were assigned to placebo had more symptoms of depression than the women who received the estradiol and the progesterone. The difference between the groups was statistically significant, and the authors concluded transdermal estrogen with intermittent progesterone is more effective than placebo in preventing the development of clinically significant depressive symptoms in perimenopausal and early postmenopausal women. So I find that quite exciting. And at this point, I do want to take a moment just to address the dosage forms that are used in these studies. You're seeing a lot of patches, and that is because there aren't that many bioidentical hormone options available commercially from big drug manufacturers. One that is available is estradiol in a patch form. My thought is that using estrogen cream, estrogen drops, even perhaps an oil-based estrogen capsule will probably have pretty similar effects. But in these studies, because that's what's available, that is what they used. Also with the micronized progesterone, you saw sublingual progesterone used in a 100 milligram capsule form. And here I believe that they were just taking the capsule by mouth. And so both the 100 and 200 milligram strengths are available commercially. And so that's what they used. But certainly I think a cream or drops, again, would be perfectly adequate. So where in the body does estrogen act? Similar to progesterone, estrogen has receptors all over the body, specifically in the brain, which is what we're talking about today, but also in the skin, the bones, the reproductive system, and the cardiovascular system. Speaking a little bit more about estrogen and progesterone, it is important to properly oppose estrogen with progesterone. It does prevent estrogen-induced endometrial hyperplasia and adenocarcinoma in the uterus, but also all of those other receptors need to be properly balanced as well. And so there again is the question, should progesterone be used in a woman that's had a hysterectomy? And my opinion, based on the information that I've gathered, is yes, progesterone has benefits in other parts of the body other than the uterus. Moving on to testosterone. So testosterone is not just for men. It is certainly made by a woman's body. And in a woman's body, testosterone contributes to sexuality, to bone health, to body composition, so basically the balance of muscle mass to fat mass. It affects autoimmune disease. It's interesting that women with lower levels of testosterone than men are more prone to autoimmune diseases. And then with regard to our conversation about mental health, PMS patients, or women with PMS, have been found to have below average levels of circulating testosterone throughout the entire menstrual cycle. And perhaps that contributes to the PMS symptoms. I wasn't able to find a study that actually showed correlation, I wasn't able to find a study that showed causation, just correlation, so I didn't share that one. So why might a woman's testosterone be low? Unlike estrogen and progesterone, which after perimenopause, as a woman enters into menopause, those levels by definition are low because the body is no longer ovulating. Testosterone, however, may or may not decline over time. And here are some examples of why a woman's testosterone might be low. 50% of testosterone production is lost when the ovaries are removed as part of a complete hysterectomy. And I think it's also important to point out that even if the ovaries are preserved and just the uterus is removed, sometimes nerve damage from the surgery itself can affect the way that the ovaries work following the hysterectomy. And so even if a woman still has her ovaries, it's important and a good idea to keep an eye on where her testosterone production is. Some other reasons might be chemical damage to the ovaries produced by chemotherapy and cancer treatments, the use of estrogen-only hormone therapies by mouth in a dry powder tablet or capsule form, and oral contraceptives, which of course are also dry tablet form. Both of these increase sex hormone binding globulin, known as FHBG, and this binds testosterone and prevents the body from using it. So a woman's total testosterone levels may be just fine, but if you test her free levels, you may find that they are low based on the use of oral estrogen. Some other reasons why a woman's testosterone might be low: treatment with corticosteroid drugs like prednisone turns off the production of adrenal testosterone. And so the adrenals may produce some testosterone directly, but a lot of that is from DHEA being converted to estrogen or testosterone. Premature ovarian failure certainly would contribute to low testosterone levels. And then lastly, loss of cycling due to lost signaling from the hypothalamus. So perhaps there's some aspect of brain dysfunction that is happening. So with regard to testosterone and mental health in women, there was a study published in the Journal of Affective Disorders, and it stated that the role of testosterone in the pathophysiology of affective disorders and anxiety is broadly supported, and evidence suggests that testosterone actually has anxiolytic and antidepressant properties. The study in the Journal of Affective Disorders looked at the MRI images of 21 depressed women, and the results supported the theory that one route for testosterone's effects on its interaction, so the reason that testosterone plays a role with anxiety and depression is its interaction with GABA levels in the brain. With regard to testosterone dosing, at this time there is no FDA-approved manufactured drug on the market containing testosterone at a dose appropriate for a woman. And we'll talk a little bit about dosing at the end of the presentation, but I will say that compounding pharmacies are able to compound any dose. And so compounding is a very good option if you're looking for testosterone for women. And moving on to testosterone for men, of course, with men, testosterone levels may also decrease with age. Again, this is not a given. However, up to 35% of men in their 70s have lower testosterone levels than younger men. And the studies have found that levels decrease as rapidly as up to 2% annually after age 30. So this can begin pretty early in a man's life. Testosterone has a critical role in the modulation of adult male reproductive health with regard to mood, as we're talking about today, sexual function, bone health, fat metabolism, muscle mass, and strength. Metabolic syndrome is greatly affected by testosterone. With regard to metabolic syndrome, as I'm sure you're all aware, the key components are central obesity, hypertriglyceridemia, low HDL, cholesterol, hypertension, insulin resistance, and this has been associated with testosterone deficiency. I've actually, in my own practice, seen really impressive improvements in men with metabolic syndrome, specifically blood sugar control, when testosterone supplementation is started. Chronic obstructive pulmonary disease, or COPD, and obstructive sleep apnea have also both been associated with testosterone deficiency. Depression and low mood are associated with testosterone deficiency. And just as a clinical pearl, make sure to keep an eye on estrogen and dihydrotestosterone when supplementing testosterone in a man. By increasing a man's testosterone levels, if they also have increased aromatase or 5-alpha reductase activity in their body, which those enzymes do tend to increase their function as we age, estrogen and DHT levels can increase. And while a certain level of each of those hormones is important for male health, levels that are too high can be quite problematic. So I do have a number of studies for men and testosterone and mental health. I think probably we're seeing more just because there are so many products on the market, commercially available products for men that include testosterone. However, just like women, men do not all require the same dose of testosterone. It can really vary based on their level and their absorption, and so I think compounding for men is quite important as well. I know that the products that are available commercially, men tend to have to apply up to 5 grams of gel to achieve their dose, whereas with compounding pharmacy, we as compounders can concentrate that so that the amount applied is much less. And there's always that concern about transference between the person's skin that's applying the gel and their family members or pets. And so a smaller site of application can be quite beneficial. So the first study we're going to look at was published in Psychoneuroendocrinology. It looked at testosterone levels in 135 men and found low serum total testosterone was associated with depression. The second study was actually a systemic review and meta-analysis. So they looked at 27 randomized controlled trials, and this involved 1,890 men. And the author's conclusion was that testosterone treatment appears to be effective and efficacious in reducing depressive symptoms in men, particularly when higher dosage regimens were applied in carefully selected samples. The third study that we'll look at here was another systematic review and meta-analysis. They looked at 16 randomized placebo-controlled trials, and this involved a total of 944 men. The author's conclusion was that testosterone may be used as monotherapy in dysthymia and minor depression, or as an augmentation therapy in major depression in middle-aged men. And I found this quite exciting. Any time that a study finds something to be effective as a monotherapy, as opposed to an add-on to previously existing antidepressant medications, I think that that is a positive outcome. And so in this situation, testosterone was found to be effective in dysthymia and minor depression. Moving on to adrenal hormones, and so I know that as naturopaths you have a lot of information here and that you're quite familiar with adrenal hormones and the idea of adrenal fatigue, but I don't want to neglect this area because it does play such an important role in mood. So just a very brief review. The adrenal medulla, which is the inner portion of the adrenal gland, produces epinephrine and norepinephrine. The adrenal cortex, which is the outer surrounding layer, produces over 40 different hormones called corticosteroids. These hormones are essential for responding to more prolonged stresses, such as physical exertion or strenuous exercise, injury, illness, infection, or worry. Hydrocortisone, which is also known as cortisol in the body, is thought to be the most important of the corticosteroids. And dehydroepiandrosterone, DHEA, thank goodness for DHEA, right, is the most abundant adrenal hormone. So what exactly is adrenal fatigue? It is also known as hypoadrenalism and adrenal insufficiency. It's a collection of signs and symptoms associated with low adrenal function. Chronic stress leads to an outpouring of cortisol, and with that, a gradual depletion of DHEA. And eventually, cortisol production is also depleted. And so I'm sure you're familiar, but usually what you see is a picture of too much hydrocortisone followed by a depletion of hydrocortisone. So adrenal fatigue can take on two different appearances. These are my two favorite books about adrenal fatigue. Safe Uses of Cortisol by Dr. William Jeffries, who of course is just a pioneer in this field. He wrote this book many years ago and was just ahead of his time. And then another book by a fellow naturopath, Adrenal Fatigue, the 21st Century Stress Syndrome by Dr. James Wilson. You probably all read this and have it earmarked all over the place. But the reason I love this book is because it talks about addressing adrenal fatigue from all directions, not just from the use of cortisol. It talks about dietary, lifestyle, supplements, all types of different approaches. And so I think that is an important idea. So some common signs and symptoms of adrenal fatigue would be weakness or lightheadedness. Of course, that low blood pressure and orthostatic hypotension plays a role. A sensitivity to cold hands and feet, which may also be a mottled or bluish color, loss of appetite, cravings for salt or sweets, alcohol intolerance, headaches, and then here we come to our mood related symptoms such as nervousness, depression, mood swings, irritability, indecisiveness, excessive worrying. I could have highlighted those as well, right? Weepiness, darkening of the skin, dry skin, light or no perspiration, sparse hair, slouching posture. So DHEA is the most abundant steroidal hormone secreted by the adrenal glands. It is an intermediate hormone and may be converted into testosterone, estrogen, progesterone, and cortisone. As I mentioned earlier, menopausal women rely on adrenal function and DHEA production to continue to have some hormonal production in their body. And so if they are experiencing adrenal fatigue, everything is affected. It's not just the DHEA and the cortisol. And DHEA production does decline with age. This is another given, much like the estrogen and progesterone that decline in menopause. DHEA peaks somewhere around mid-20s and then declines over the years. And so we expect to see lower levels of DHEA in older people. Why might you consider DHEA? If you're looking at infertility, low libido, menopause, osteoporosis, cardiac health, aging skin, dry eye syndrome, depression, and any issues with memory and cognition. Here's a study that was published in Current Drug Targets, and it looked at the effects of DHEA in the treatment of depression and depressive symptoms in other psychiatric and medical illnesses. Researchers searched well-known scientific databases. They found 183 references and selected 22 to compose for their review. The researchers observed significant improvements related to the use of DHEA in patients with depression. They also saw improvements in depressive symptoms in patients with schizophrenia, anorexia nervosa, HIV, and adrenal insufficiency. And so with some of these intermediate hormones, it's a little hard to know, was it the DHEA specifically that caused these improvements, or was it the estrogen and testosterone that the DHEA was converted to? It's really hard to know, but it is important just to note that the outcome was improvement in these symptoms. A relative of DHEA, and we won't talk much about this, but I just want to make sure that you're all familiar with it. 7-keto-DHEA is actually a form of DHEA that is produced when the hormone is metabolized. So DHEA can be metabolized into testosterone, estrogen, as we talked about. It can also be metabolized into 7-keto-DHEA. And the thing that's a little bit unique and special about 7-keto-DHEA is it is not a precursor to estrogen and testosterone. So if for some reason a patient is not a candidate for estrogen or testosterone therapy, 7-keto-DHEA may be an option in that situation. Moving along to Pregnenolone. So as we mentioned before, and I'm going to show you that chart again one more time because I love it so much. Pregnenolone is the mother of all hormones. It is at the very top of the steroid hormone cascade, and it's produced from cholesterol. So here's that chart again. And so as you can imagine, if the pathway between cholesterol and Pregnenolone is not working well, we're not even getting started. We don't have a chance to have balanced hormones in any part of the cascade. And two things that really contribute to that pathway are thyroid function, interestingly. So if somebody is experiencing hypothyroidism for whatever reason, and we'll talk a little bit more about that later, the cholesterol is not getting converted as it should to Pregnenolone. Oftentimes, I think you'll notice that somebody with hypothyroidism may also have high levels of cholesterol, and that's because that cholesterol is getting backed up. It's not entering the pathway here. The second factor that is important to this particular conversion is vitamin A. So good to look at vitamin A and make sure patients are getting adequate amounts to get that cholesterol moving on to pregnenolone and then converting the hormones throughout the pathway. There was a study that was published in Neuropsychopharmacology, and it examined the use of pregnenolone to treat depression and bipolar disorder. And I think if any of you are familiar with bipolar disorder, the depression aspect can be very difficult to treat because many of the current available treatments tend to have a risk of inducing the mania portion of bipolar. And so in this situation, 80 adults were randomized to receive either pregnenolone titrated to 500 milligrams per day. And let me stop there because 500 milligrams per day, wow, that is quite a dose. I would say on average, we see doses somewhere between 10 milligrams and maybe 50 milligrams per day, 10 and 50 milligrams per day. However, perhaps we're not using enough. Pregnenolone is one of these hormones where, similar to DHEA, it's an intermediate hormone. And so it's hard to know what part of the effect is due to pregnenolone and what is due to the hormones that are being produced downstream in that pathway. Perhaps we're not using enough pregnenolone. So in this study, particularly, 80 adults were randomized to receive either pregnenolone at 500 milligrams per day or placebo as an add-on therapy for 12 weeks. So this was not monotherapy. These patients were already receiving pharmaceutical therapy for their bipolar disorder. Depression remission rates were greater in the pregnenolone group at 61% than in the placebo group at 37%. The authors concluded pregnenolone was well tolerated and may improve depressive symptoms in patients with bipolar disorder. So that's great news, first of all, that we saw improvement in the depressive symptoms, but also that it was well tolerated at 500 milligrams per day. That leads me to believe that perhaps if somebody isn't seeing an effect that they wanted to see from pregnenolone, perhaps pushing the dose would be appropriate. Moving on to thyroid, and I get, again, like with adrenal function, I know as naturopaths you all have a very good base of your thyroid knowledge, but again, thyroid plays such a role in mood and mental health that I didn't want to leave it out completely. An estimated 40% of the population has inadequate thyroid activity. That's almost 1 in 2. That's pretty incredible to me that many people are struggling with thyroid issues. Thyroid hormone has receptors in every cell of the human body, and it directs the metabolic rate. And so I consider adrenal function and thyroid function to be base functions. If the adrenal system and the thyroid system aren't functioning or aren't supported adequately, you're really not going to see true benefit from supplementing with the other sex steroid hormones. And so it really is important to get the adrenal and the thyroid systems supported, if not before starting the other hormones, because the other hormones can provide support. It is certainly something that cannot be ignored. Classic symptoms of low thyroid include depression and anxiety, fatigue, dry skin, water retention, heat and cold, intolerance, constipation, impaired memory, loss of hair, indigestion, muscle and joint pain. And I look at those symptoms and I think in traditional medicine, what types of symptoms are being watched for? I think probably the dry skin, probably the fatigue, maybe the hot and cold intolerance, maybe constipation. But I rarely hear from the patients that I speak to that their traditional medicine practitioners are asking about depression and anxiety. And in my experience over the years, these two factors, these two symptoms play such a role in hypothyroidism, and I think that they're so important to address and consider. With regard to thyroid testing, first we'll talk a little bit about thyroid physiology. The two main thyroid hormones are T3, liothyronine, and T4, levothyroxine. Of course, there are other thyroid hormones that exist, such as T1 and T2. I know calcitonin plays a role, but these are the two that most look at most often. And as you're all familiar, the T4 needs to be converted to the active form T3 before it can be used by the body. I like to look at the thyroid gland as a car. I think in traditional medicine, the practitioner may look at TSH and see it's high and start some T4 and the TSH comes down and it's all good, right? No. And so there are so many different things that can be happening with the thyroid. It's not just a matter of not enough T4 being produced by the body. Perhaps the car is out of gas and we need to provide the building blocks for these hormones in the form of tyrosine or iodine. Perhaps there is an issue with the conversion. Perhaps the starter isn't working and the T4, for whatever reason, isn't being converted to T3. And that can happen due to reduced levels of supplements, selenium and things like that, but also due to the presence of certain toxins in the body, like heavy metals, either due to dental work or other exposure, pesticides, other toxins. There are stress. There are a number of reasons, a kind of a long list of reasons why T3 may not be converting to, or I'm sorry, why T4 is not converting to T3. It's possible that the T4 is being converted into reverse T3, and that can happen also due to stress. The body begins to convert the T4 into a form of T3 that is not as active in the body, and that doesn't provide the stimulation and the direct metabolism that the T3 does. And also moving on to antibodies, we're seeing more and more Hashimoto's. The incidence of Hashimoto's in the years that I've been in pharmacy is just amazing. It's so high. It's something that when I started wasn't really talked about very much at all, and now it seems like more thyroid patients that I talk to than not have a Hashimoto's diagnosis. And so in this situation, it's important to look at testing that is above and beyond just the TSH, looking at free T3 and free T4 levels, reverse T3 levels, testing for antibodies like the thyroid peroxidase antibody, TPO, which can indicate Graves' or Hashimoto's thyroiditis, and also thyroglobulin antibody, which actually targets the thyroglobulin, the storage form of thyroid hormone. When looking at TSH, the standard range currently is 0.38 to 5.5 milliunits per liter. However, I would consider looking at any patient who has a TSH above 2 milliunits per liter. And in that situation, as naturopaths, I know that this is your focus and that you're always looking at patient symptoms and how they're feeling, and thank goodness for that. But I just, even if their TSH is not above that 5.5, I would look closer if it's above the 2. And as I mentioned before, if thyroid function is low, often cholesterol is high. And so this is all I have for the hormones themselves and how they relate to mental health. However, I did receive a request to talk a little bit about dosing and what we see most often with regard to dosing, and maybe to touch on testing a little bit. So I'll do that now. At the pharmacy, we most often see estradiol and estriol combined into either a capsule or a cream or a gel. We see all different dosage forms. I would say perhaps the topical form is a little bit more common. But with regard to dosing, I would say somewhere between 1.25 to 2.5 milligrams once to twice a day is the most common dosing that we see. And what that breaks down to is the estradiol at either 0.25 or 0.5 milligrams, and the estriol at either 1 milligram or 2 milligrams. And many women do just fine using the estrogen once a day. We're all individuals, right? It really depends on rate of metabolism and absorption and so many different things. But some women do find that if they don't use the estrogen twice a day, they do start to develop breakthrough symptoms during the second half of the day. And so what we see most often is starting at once a day and then increasing to twice a day if needed. With regard to progesterone, most often, well, first I'll say that the dosing differs between premenopausal women and postmenopausal women. Women who are still having a regular or somewhat regular cycle, actually, we usually receive higher doses of progesterone than those who have passed through into menopause. For the 2 weeks prior to the cycle, we see somewhere between 100 and 200 milligrams per day. And to pause for a moment, these are all averages. Of course, we see lower and higher and all over the board, but just to give you some averages and to explain to you what we see most often. And so women that are premenopausal and are still cycling, usually we see doses of 100 to 200 milligrams per day, and oftentimes in a capsule form. The capsule does have more of a drowsy effect than the cream. The cream can still assist with sleep if the patient is struggling to stay asleep. However, if they're having a hard time falling asleep, it would make sense to start with a capsule form, because the way the capsule is broken down, there are metabolites that are formed that do increase drowsiness. Once a woman's periods have stopped and she is in menopause, then the doses that we see range somewhere between 50 and 100 milligrams per day. And oftentimes it depends on the estrogen dose. If the estrogen dose is near the low end, perhaps a little lower dose of progesterone. If the estrogen dose is a little higher, perhaps a higher dose, but always looking at symptoms, of course. There are some very obvious symptoms of low estrogen and low progesterone that can be used to indicate when a dose increase may be needed. And then on the other hand, there are very specific symptoms of excess that can be used to know when the dose should be backed off on or lowered. With regard to testosterone, we see very wide ranges of testosterone dosing for women because, as I mentioned, unlike estrogen and progesterone that by definition fall in menopause, testosterone may or may not fall. It may decrease slightly, it may greatly fall, it may not, there may be no production at all. And so we see doses somewhere between maybe a half a milligram up to maybe 10 milligrams or even 20 milligrams a day in certain situations. With regard to DHEA, I think it's really important there to consider the dosage form. With DHEA tablets that are available without a prescription in supplement form, I think we're almost used to seeing maybe 25 milligrams, 50 milligrams. However, if you're using that in a cream or an oil-based capsule, you'd probably want to back off because you're preserving more of that. It's not being broken down by the digestive system. And so there maybe you would see 5 milligrams, 10 milligrams, 15 milligrams, and kind of start there and perhaps increase. I mentioned the dosing of Pregnenolone, which, as I said, we see maybe 10 to 50 milligrams. However, the study used 500. So I will tell you, if I saw a 500 milligram dose prescription come in, I would probably contact that practitioner just to confirm. And then touching on testing just a little bit before we go here, we do see a fair amount of testing of the hormones that don't necessarily decrease over a person's age. So, for example, the testosterone in women, perhaps DHEA. I don't see too much Pregnenolone testing just because I don't know that we really have an idea of what those levels should be. However, with regard to testing estrogen and progesterone, I think that that's fine, that would allow you to get an idea if those levels are very, very low or off the charts. However, it's very hard to know where within the normal range those levels should fall. And so maybe a baseline test would be good to see where you're starting. But after that, we mostly see practitioners use patient symptoms to address dose adjustments and dosage form changes and those types of things. And so, I did forget to touch on testing, or I'm sorry, on testosterone dosing for men. Most often, I would say 50 milligrams is the intro dose. And I think that comes from the fact that is what many of the commercially available products begin with. And I think that's fine. I can tell you that we do see dosing anywhere starting from 10 or 15 milligrams all the way up to 200. I think I once saw somebody on a dose of 400, and that's what it took to get his blood sugar under control. So there is certainly a wide range there as well, even though the generally accepted dose is 50 milligrams. So that concludes my presentation. I'll move on to my last slide here. That is my information. And please feel free to reach out. I would be very, very happy to communicate and correspond with any of you. I'm sorry I couldn't be here today in person. I would love to answer any questions that you have. Please feel free to reach out. And thank you so much for having me today. As you can tell, bioidentical hormones are a real passion of mine. I really feel that's what the body is looking for with regard to hormonal therapy. We can accomplish amazing things with regard to obtaining hormonal balance. And so I am always so appreciative of being able to share information with colleagues and to gain your insight as well. So thanks again for having me.